Finance and Policy. It is March 8th. First on our agenda for the record, members, we do have a quorum. First on our agenda today is Senate File 1535, Senator Duckworth bill. And if Senator Draheim, you are a co-author, if I could, Senator Draheim moves Senate File 1535. Senator Duckworth, please proceed.
Thank you, Madam Chair and members. I greatly appreciate your time. This is a bill that changes access to birth and death records and who can request access to those records. And Madam Chair, I would love to turn it over to Ms. Crawford at the Minnesota Department of Health, who can provide some context regarding this bill.
Ms. Crawford, please introduce yourself and proceed.
Thank you, Madam Chair. My name is Molly Crawford. I am the State Registrar for the Office of Vital Records at the Minnesota Department of Health. And in that capacity, I oversee vital records for the state of Minnesota, including the local issuance offices across all the counties. I'm happy to speak on behalf of this bill. It secures access to both birth and death records. And it also does an important thing in plain language. I'll address the first thing, that is securing the access. So the current law is for both birth and death records. And this bill tightens security for the legal certificates issued for birth and death certificates. Death certificates aren't such a concern, but birth certificates are, because they are identity documents used by individuals to get access to services, benefits, and other ID documents. And so securing access to them is important for security and fraud prevention purposes. This bill would eliminate from those eligible to get legal birth certificates and death certificates the party responsible for filing the record. So for example, this would be a hospital birth clerk who collects data from a mother who's just given birth to register her child and create a birth record. Under the current law, that hospital birth clerk could go get a legal birth certificate for any of those infants for which that birth clerk is registering the birth. There is no business need to obtain those legal documents. Hospitals have access to data for the records that they file. And so this bill would eliminate that possibility. It also changes language related to licensed attorneys. The current law allows licensed attorneys to get both birth and death certificates. The language in the bill would require those licensed attorneys to have to represent either the subject of the record or a person who's eligible to get the certificate, such as a parent or a spouse. Finally, the language in the bill allows for individuals to have an easier understanding. Using plain language in the bill, we're eliminating the language referring to tangible interest. So a party would be eligible to get a certificate rather than having to have tangible interest. When we explain who can order a birth or a death certificate, sometimes our customers, our Minnesotans, are confused. And so this would help that along. So thank you.
Thank you. Senator Duckworth, comments?
No, Madam Chair, pretty straightforward. I don't really think I have anything additional to add. Ms. Crawford did a phenomenal job. Happy to answer any questions if there are any.
Thank you. Questions from members? I'll give a few minutes. And seeing no hands, members, I'll remind you to turn on your video, unmute. We are going to a vote. Senator Draheim renews his motion that Senate File 1535 be recommended to pass and referred to the Committee on Civil Law. All those in favor say aye.
Aye.
Aye. Any opposed? Hearing none, thank you, Senator Duckworth. Senate File 1535 is on its way to civil law.
Thank you.
Enjoy
Thank you,
civil law. Have a good day.
Take care.
Members, thank you for your attention. I'm going to have Ms. Strand send out a report that was released today. The Itasca Project, the first 1,000 days, it deals with child development, and there are some significant ways that they have identified to help child development that fall within our purview. One of the things that they highlighted as I briefly read the report today was that brain development begins prenatally, and it is the very earliest days that really help set the path for brain development. And yes, brains continue to develop throughout childhood and into early adulthood. But it really emphasizes the importance of early days. And if you've raised children and watched them, you know that reading to them and having eye contact and holding them, those are all really important things to help their emotional stability and their brain development. And this report does help support some of those things that you know as you watch children develop. We also know that there are some families who struggle. There are some moms, well, every mom needs a support system, but some moms don't have a robust support system. And so to try to solve some of the challenges that we see through human services, whether it's mental illness or need for specialty services, we're going to have some pretty intense conversations about ways we can help moms and babies in those very earliest days. The Itasca report talks about adverse events and how that impacts a child. Talks about nutrition, including breastfeeding, which is one of the ways that we can help support moms as they try to connect to their babies. Let me be clear. Everything we're going to do today is about meeting moms' needs, but the moms get to choose it. This is voluntary, and we're going to hold people to outcomes. If we're going to give people money with the idea that it's going to help moms and babies, then we need to be willing to hold people to outcomes. And everyone that I've talked to about this is willing to be part of a partnership that says we'll take care of those very earliest years and we're going to change the trajectory of the lives of those families. Nothing we can do today replaces family support, but we can supplement and maybe help change the lives of people who don't have that robust support system that we all know is so important. So again, families really matter. For people who are struggling, we're going to see what we can do to help them in our budget. Our first presentation today is going to be an overview of existing programs from the Minnesota Department of Health and then the Minnesota Department of Human Services. So we're already spending money in these areas, and I wanted us to get an overview of what was being spent and are we holding folks to high standards. So let's start with the Minnesota Department of Health. Karen Fogg from Maternal Child Health and Don Rickinger from Home Visiting. We asked you to prepare about a 10-minute presentation and then prepare for questions from the committee. So welcome to the committee. Introduce yourself and proceed.
Sure, I can go first. My name is Dawn Reckinger. I'm the manager of home visiting at the Minnesota Department of Health. And Karen and I are kind of splitting up, so I'm going to go for a couple minutes and then she'll present her programs. I'm going to share my screen. Can you guys see a slide deck? Okay, good. There you go. So briefly, what is family home visiting? So home visiting is a voluntary service for pregnant women. Ideally, we start then, but we also recruit women usually up to age when the baby is about 3 months old, for families most in need of services. So what happens is a trained home visitor conducts a home visit that begins prenatally and continues to the early years of a child's life, often age 2 at a minimum and often going to age 3, 4, or 5, depending on the needs of the mom and the community and how they what program of services they've chosen. Home visiting works to connect families to community services. It supports parents early in their role as child's first teacher. It helps parents develop safe, stable, and nurturing environments. It helps support healthy development for the baby and other children in the household. And it fosters parenting skills that decrease the risk of child abuse. How does it work? The majority of home visiting programs are long-term, and that's where we mean it's ideally more than 6 months, 4 to 6 months of services. That anything less we would consider short-term. Longer-term usually is, to be honest, about 2 years or more. Again, serving families starting prenatally to shortly after birth, where they start. Visits are closer together when mom is first home with baby and probably needs the most support and has lots of things going on, plus a new one to take care of. So they often are weekly up until the child is a good 6 to 12 weeks old, and then they sort of space out as the child develops. Most home visiting programs begin, again, gradually decreasing as mom or dad hone skills, get connected as the child grows and develops. Here's some things that we include in a typical visit. It would address the child's development. There might be some screenings to make sure the child's on track. They would go over safety situations in the household, making sure other family members or friends that are interacting with the baby are, handling the baby correctly. There's no shaken baby syndrome, that the baby's on track for its developmental milestones. Definitely addressing mom's issues. Mom might have some goals that she wants for herself, continuing her education, getting a job, learning how to parent in a different way than she might have been raised, dealing with postpartum depression, so making sure that we connect the mom to all the resources and get the information she needs. And then working a lot on goals and skill building. Again, this is all voluntary. These are parents who want to do better for their child and just want a helping hand getting off to the right start. So it could include problem solving, or learning how to navigate all the support systems we have, and then again, practicing parenting and communication skills. This is just sort of a quick slide. On the left, you'll see sort of a one color map, and if it's purple, it means that there is an evidence-based home visiting program in that county. And what it doesn't show in here is 8 of our 11 tribal nations actually have an evidence-based home visiting program as well. I'm happy to say we are about to color in a few more of those. If you're a rural county, sometimes doing an evidence-based program can be a challenge, but we are just about to bring in Couchiching, Crow Wing, and Sibley into this. So on the right-hand side, it kind of talks about the amount of children that are under 200% of the poverty line and under age 4, which is sort of a marker that DHS, MDE, and MDH have agreed on to talk about when we say how many families need this service. You'll see that in 2020, we served 11,992 pregnant women. Not many of those were with short-term home visiting services. Probably a little less than half were with what we'd call those long-term, more 2-year home visiting services. So again, we had 81 counties, 8 tribes, and 19 nonprofits that are implementing evidence-based, and again, about to add 3 more counties to that list. Just a quick overview of our funding. MDH oversees $36 million per year in federal and state funding. We have $8.5 million in the TANF funding allocation, which is Statute 145A-17. 50% of that, as written into the rider every year, must be used for home visiting, while more than 50% is used for home visiting. On average, we get about $9 million per year in MCV funding. That fluctuates a little bit every year. We have $2 million in NFP state funding, which began in 2015. And then there's the new funding of $16.5 million per year that started in, was allocated in 2017. If you look at the comprehensive picture, 75% of this funding must go to evidence-based home visiting programs. And I think that's it. So I don't know if you want to take questions now or go to Karen and then. I think you might be on mute, Senator Benson.
Sorry. Let's proceed with Ms. Fogg, I believe is how she pronounces her last name.
Yes, that's correct. Thank you, Chair. I'm Karen Fogg. I'm the Maternal and Child Health Section Manager. Don, I need you to stop sharing so I can share my slides. Thanks. Sorry. So thank you everyone, and thank you, Chair, for allowing us to have this opportunity to talk about the maternal and infant health programs at MDH. There's quite a few, so I'm going to have to go quite quickly, and I may even have to skip one or two. If members have additional questions about any of the programs, we're happy to provide additional information either this afternoon or separately at a different time. So first is the Title V Block Grant. It's a federal, state, and local partnership, and it's a key source of funds to support Minnesota's mothers, children, and families. It's about $9 million of federal funding every year. By statute, $6 million must go to local public health. There's an additional required 75% state match to this funding. It's widely used across the state and is really the foundation of a lot of our maternal and child health work in the state. For the 2020 through 2025 time period, we have 11 priority areas, including the ones I've listed here that are focused on the care of women and children in those early days. Local public health uses these funds very flexibly to support the local needs identified in their area. As one example, Ramsey County has the Birth Equity Community Council, which engages with the communities to prioritize activities that will improve birth outcomes up to 1 year old. And so they've created a really great program called Doula Dads, which helps engage and train fathers as perinatal educators. We also do work in birth defects prevention and screening. So we have some new grants right now trying to embed preconception care into those well child visits. So getting those women to make healthy decisions to prevent birth defects before they're pregnant another time. We also have some community grants in that program working to address most common risk factors. And then we serve about 2,000 families additionally through the birth defect screening system, providing appropriate support for those affected families. For maternal health, we have the Maternal Mortality Review Committee. This multidisciplinary committee reviews every maternal death in the state, releases recommendations about how those deaths could be prevented in the future through changes in systems, practice, and even patient education. We also have the Minnesota Perinatal Quality Collaborative, and MDH is the co-chair with the Minnesota Perinatal Organization. This group seeks to improve the quality of prenatal labor, delivery, and postpartum care through a network approach, engaging organizations, medical providers, and community voices around specific issues. Right now, they have three sort of initiatives going on at the same time, one about premature birth prevention, one on maternal opioid use, and the other on hypertension. We also have the Positive Alternatives Grant Program. So this program supports healthy pregnancy outcomes and stability of families in those early days through nonprofit organizations. We have 27 brand new grantees starting up just this year. To address disparities, 3 programs I wanted to draw your attention to. One is the PRAMS, Pregnancy Risk Assessment Monitoring System. It's a population-based survey and collects data on experiences of women throughout the state that's collected nowhere else. And it's widely used data that we provide in summary to groups who request this information, but provides information about smoking during pregnancy and other things that we don't get in other surveys. We have the Eliminating Health Disparities Initiative grants. Infant mortality and teen pregnancy are 2 of several priority areas that these community organizations could have selected for their programs. And a newer effort is the Calling All Sectors Learning Collaborative, funded by the Pew Charitable Trust and the Robert Wood Johnson Foundation. It's a partnership between state and community organizations, and we're seeking to ensure that no child is born into homelessness. On infant health, we do a lot of work around surveillance of infant mortality, which we can all agree is a really difficult issue here in our state. And we do other surveillance of other infant data like breastfeeding rates, and I'll talk about that in just a minute. We promote safe sleep through education, information, and even working with hospitals to promote best practices. Governor Walz proclaimed that a week in November as Infant Safe Sleep Week in Minnesota. And we have broad distribution of safe sleep materials. You'll see one here in the slide in a variety of languages to serve all Minnesotans. We also have bereavement support available for families following the death of an infant or a stillbirth. And I would be remiss if I didn't just briefly mention the WIC program, which you're all familiar with, I'm sure, for the food and nutrition assistance that they provide. But in addition, the WIC program is instrumental in supporting breastfeeding throughout the state. They also promote peer breastfeeding support, the mother-to-mother support, and they've done some great work with women of differing communities, providing culturally specific breastfeeding support, which has really changed outcomes in the state. So that was a quick run through. Thank you, Chair, for the time.
Thank you. Questions from members? Waiting for hands. Senator Rosen.
Thank you, Madam Chair. And Ms. Reckinger, I think it is. Could you explain the counties that have not been on your slides? You had the map that are not working with MDH. What are they doing then for their home care visiting program? Because a couple of them have communities that are quite large.
Sure. Thank you, Madam Chair and Senator Rosen. So 2 things. We went through the slides really quick, so I just want to make sure all 87 counties and 9 of the 11 tribes receive TANF allocated funding through 145.8.17. Prairie Island and Shakopee turn it down. But so all of them are required to have some form of home visiting. That legislation does not require them to have an evidence-based form of home visiting. So just be assured, no matter where a child lives in the state of Minnesota, they do have home visiting available. There has been a large push nationally in the last 20 years, mostly because we're lucky to be in a field that has so much strong evidence behind it. And so such a proliferation of models and home visiting programs, everything from ones that are geared specifically at American Indians to small rural counties. If you notice on the slide, the 6 that were left, now 3, are all rural counties. And some of our home visiting models that we've had in the past or that have been available are great models. They might require 100 births. So Kitson County does not have 100 births per year. They feel like at full capacity for long term, they would probably serve 5 families given their capacity. We actually have recently, so as a state, we work to try and bring in models and how can we support all communities. So we actually have recently brought in an evidence-based model that is nurse-based. We're really unique in Minnesota that like 400 of our home visitors are nurses. So Kitson County actually is going to take on this new model. The pandemic, as you might imagine, is getting in the way of quite a few things. We've also had extensive conversations. Nobles was the last one. On the slide. They also are very interested in looking at some models. I think, again, the pandemic kind of got in the way. I would say Blue Earth County itself feels that one of the nonprofits in the area, that they work well with them. They're only serving Mankato, so we don't quite fill in the whole county. But those are usually the reasons. Kuchiching, Crow Wing, and Sibley just got funded and were able to come in because we opened up some access to models and we're providing a lot more state support so they don't have to do it all on their own, or we've helped to get them connected to multi-county collaboratives. It's just really hard for a small rural county to kind of take on all the administration. So we've tried to gear our funding so that collaborations are supported. So regions of home visiting can be supported. And I think we've been successful in that.
You, Senator Rosen, anything further? I just wanted to ask either you, Ms. Reckinger, or Ms. Fogg, how do we know this is working? What do we measure? Do we measure NICU days? Do we measure moms who are nursing? How do we measure that? Because I think a lot of Minnesotans are willing to invest in programs that help moms through those early days, which even with the best supports can be really tough. But how do we know it's actually having an impact on the lives of children and families?
And I'm going to let you go first, and then I'll go because I talk too much.
And that might be kind of an unfair question, but are there any reports that we get that we see that women who participate in these programs are more likely to have kids who, are reading by grade 3 or are employed? Or help me understand what metrics we could use or are using.
Thanks, Senator Benson. I think that that the last example you gave, those long-term, that long-term work is not is mostly based in research, right? So the fact that a mom would choose to breastfeed and reading rates is not something that we could regularly measure at the state level. But I think that one of the things we should be thinking about is looking at the disparities that are persistent in all of the measures that we're looking at. So we're looking at urban, rural. Those are important things, but also in the state thinking about are we doing the best to reduce the current disparities in infant mortality rate or maternal mortality rate, or thinking about the prevalence of morbidities, and then thinking for like maternal morbidities, for instance, so thinking about something like hypertension and looking at the disparities in rates of hypertension. So I think getting more granular, and I know that our WIC program is really leading the way in looking at the disaggregation that they've been able to do with the breastfeeding data, going beyond race and ethnicity to look at ethnic groups. So they have a much larger population, and some of our statistics have a very small number of cases involved in the denominator. But when we're able to do that by disaggregating data and looking at where the differences are and then measuring the trends over time, are we able to reduce the disparities that we're seeing? That's a really important and critical component of the data work.
And then thank you, Madam Chair. I can quickly speak for home visiting. So we, as part of our federal, we refer to it as MICV. It's Maternal Infant Early Childhood Home Visiting. It's the full name. We refer to it as the MICV funding. There are 19 federal benchmarks that we track. Everything from, was this child, did they get all their immunizations? Was the mother screened for a postpartum depression? Did she get a referral for postpartum depression? Did she follow up with the referral? Looking at child developmental screening. So there's a wide variety, and I'd have to get the list, and we can certainly send that to you of what those 19 benchmarks are. So we have that, and we implement that across the state. Our MICV funding allows us to build that sort of state infrastructure. So the evaluation isn't just for grantees to receive the MICV funding. We actually are able to do it for all of our grantees. There is a report that is due it's due this coming year. You just received it 2 years ago. So January 15th on the 145A.17, it's written into that legislation that there will be a report on that specific, the $8.5 million in TANF funding. We have typically included all of our funding in that report so people get a comprehensive view of home visiting. I'd be happy to send the members a copy of that report as well. We actually just have a new data system that went online, luckily in January of last year, right before the pandemic, because most of our sites use electronic health records. We have multiple electronic health records, so we're able to aggregate the data in one spot. And the abilities now in the last 6 months, despite the pandemic, of being able to see where are the rates, what are the screening rates, what are the referral rates, how can we help those agencies get the moms more services that they need. Basically, continuous quality improvement is just a huge step forward for us. And I think we'll be able to show the state a lot of where the services are and how we're doing.
Excellent. Senator Nelson.
Thank you, Madam Chair, and I just thank you so much for really today's hearing and highlighting the importance of these very early years, and for the review of the state programs, federally funded, state implemented programs that we have. And there was a little bit of discussion about outcomes and metrics. And I know, I think Ms. Reckinger mentioned some of those key markers that we know are so critical. I'd like to get a little more information on one of those key markers, particularly when we're talking about our under 5 age kids with family child home visiting. What percent, how much more likely is a child in family child home visiting through your programs to be ready for K than a similarly situated student, same demographics, all of that, who has not had family child home visiting through our state or federal programs?
Who
Okay,
would
thank you.
like to take that?
I can take that one. Thank you, Madam Chair. Thank you, Senator Nelson. So I'm going to refer a little bit back to what Karen Fogg alluded to is, so our databases, the data we collect often go up to the child's age 2 or 3. As you may know, there is a large effort to try and combine multiple data sources, unidentified, so that we could look at a child from their birth record, not a child, but the identified of, like, if we know a child was born with this, if they got home visiting, how did they do, in kindergarten? We don't quite have that capability right now. So right now we look at the years that our program is provided, and we rely on the larger research of randomized control trials that show if a child gets this, it minimizes the adverse risk factors that both mom and baby are exposed to. So we would love to be able to say, if a child is in this, they're reading at this level by 3rd grade or kindergarten, but our data systems don't connect that way.
Madam Chair, just to follow up, please.
Senator Nelson.
Regarding those randomized clinical trials, that is the gold standard. And I know that there are some entities, maybe not run through maybe they're not our state programs or our federally funded programs, who do have that data. And I'm just wondering, it is so critical. These kids don't have a second chance, to be ready for K. And so it's really important. And I'm just wondering, what is it that is standing in the way of Minnesota getting that really gold standard of efficacy, which are those randomized clinically controlled trials? Similarly situated kids in two different pre-kindergarten programs, or one in the programs that you're speaking of, and one who doesn't have that, who's not experienced those. What's standing in the way of getting that really necessary data to best evaluate our programs?
Ms. Rickinger, if you'd like to, but we do have Senator Coleman's carrying a bill that would kind of consolidate some of our nurse visiting. And as we look at information and can start tracking longitudinally over time, I think you're going to find we're trying to raise the requirements for this money so that it goes to places that are effective. But at the same time, balance the concern that some of our ethnic populations and minority populations might not have those peer-reviewed gold standard studies. And so we're going to continue to raise the standard, but we need to also make sure that we're not setting the bar so high that it leaves out the people who might benefit from this greatly, who haven't had access before. So we're going to keep trying. But
thank you, Madam Chair. And I would say the ones that exist are very diverse in the makeup of those parents and students. So we'll hear more perhaps in the next segment as well. But I do thank you for shining the light on this. And it is so important, and it is important that we do have those really that gold standard in evaluating our effectiveness of our program. So thank you, Madam Chair. Thank you.
Thank you, Senator Nelson. We're going to move on to the Department of Human Services. Dr. Nathan Chamilo, if I mispronounce your last name, I sincerely apologize. Welcome. We have about 10 minutes for your presentation. We want to look at integrated care for high-risk pregnancies. So if you could, Senator Wiklund's going to have a bill later about expanding MA. So if, as you're choosing what you're going to cover in the next 10 minutes, I'd appreciate it if you could focus on that. Thank you.
Thank you, Madam Chair, and thanks for having me. And I wanted to echo the comments of thanking you for having this important conversation. I'm a pediatrician, an internist, and serve as a half-time Medicaid medical director for the Department of Human Services. And so happy to be here today to present to the committee on our work with maternal and infant healthcare coverage and medical assistance. And so going through just our enrollment in Minnesota, if we look at a significant number of births and even more children rely on medical assistance, our form of Medicaid, for their health care. And so MA covers 4 out of 6 of the births in the state and nearly half of the children. But these numbers are even higher when you look at specific communities. And so if you look at birthing persons who identify as Indigenous, we cover 9 out of 10 births on our Minnesota healthcare programs. And for those who identify as Black, it's 8 out of 10 births through our Minnesota healthcare programs. And so we've heard often about our state's racial disparities in maternal health outcomes, and seeing how many of our mothers from those communities we cover, Medicaid is really essential. And similarly, we had Lynn Blewett and her shop at Shadak look at how do children get access to healthcare in Minnesota, and this is based off of data from 2018. And so what you can see, if you look at, depending on the community, the dependence on Medicaid as their source of healthcare coverage is different. So 64% of children who identify as Black in Minnesota get their healthcare coverage through Medicaid versus 54% of our American Indian, 52% of Hispanic, 31% of Asian, 17% of white children. And then there's a notable number of other or missing data there too. But it just shows you that investments in our programs impact communities differently. And so this kind of shows the kind of geographic reach, and Medicaid is the 3rd largest insurer in Minnesota after self-insured employer-based coverage and Medicare. Enrollment being split pretty evenly between the 7-county metro area and greater Minnesota. There is a larger percentage of population in greater Minnesota enrolled in the program, and children overwhelmingly actually make up the largest category of enrollees, but spending on their coverage ranks amongst the lowest. And again, just showing that parents and children consistently remain the largest segment of our covered population. The 2020 average monthly enrollment was around 734,000 parents and children. And then again, just looking at how that money is spent, particularly looking at children 0 to 5, around 313 million, or about 39% of the money spent on 0 to 5 was in hospital services. And then you also can look at how spending was on parents and pregnant women in 2019. And so the eligibility factors for pregnant women are different than non-pregnant adults and Medicaid. And so just a reminder that a pregnant woman within the postpartum period or during a pregnant period is eligible for up to 2 months to be covered via medical assistance, and that the income thresholds are different for our pregnant women than they are for adults who are not pregnant. And there is no asset test. And then similarly, there's different thresholds for children. And so all children born to mothers currently enrolled in medical assistance at the time of birth have automatic eligibility through at least their first year of life, as long as they're a Minnesota resident. Infants through age 2 have different income thresholds than those children between the ages of 2 and 18. And then children, older children have different eligibility factors as well. We want to touch a little bit on doula services and Medicaid coverage of doula services. So doulas provide guidance and physical and emotional support to pregnant women. This has been shown to reduce preterm birth, reduce the C-section rate, and improve overall feelings about childbirth, and even decrease use of pain medication postpartum. With some evidence even suggesting that increasing Medicaid coverage could actually decrease spending by decreasing C-sections alone. And so since 2014, Minnesota has covered doula services through our Medicaid program. We were the second state in the country after Oregon to do so. And covered services are limited to childbirth education and support. Include up to 7 different sessions, including one for labor and delivery, and the remaining 6 sessions can be used in the antepartum or postpartum, so even before or after birth. And in 2019, the legislature did agree to raise rates of those sessions as well. And so the Integrated Care for High-Risk Pregnancies program was in 2015 part of mandates by the legislature to implement a pilot program to improve birth outcomes for some of our highest risk births. And so the program is using grant funds to promote integrated care and enhanced services to women at risk for adverse outcomes like low birth weight and preterm birth through the use of these perinatal care collaboratives. And so these care collaboratives really support the interdisciplinary team-based needs assessments, infrastructure planning, implementation of integrated care for pregnant mothers in the targeted populations. And we know, looking at our disparities data, that mortality rates for African American and American Indian women and infants are much higher. And so those are the populations targeted in this pilot program. These collaboratives try to use these perinatal models to really help integrate initial psychosocial risk screening. And so the care workers are into the paraprofessionals, which are usually doulas or community health workers, do an actual initial screen with mothers to kind of then connect them to services as needed. And this is all in a community-based approach. And the goal is really to decrease these birth disparities by directly supporting a model that is based in the community and led and guided by the community's input. And so there's the African American ICHIRP, is integrated, we affectionately call it the Integrated Care for High-Risk Pregnancy Program. And then there was a tribal ICHIRP as well. And so that funding was specifically for 5 different tribal nations: the Fond du Lac Nation of Lake Superior Chippewa, the Leech Lake Nation of Ojibwe, the Mille Lacs Nation of Ojibwe, the White Earth Nation of Chippewa, and the Red Lake Nation of Chippewa Indians. And so initially, consultants were brought in from the African American community to gather a community-led advisory board that facilitated conversations with mothers experiencing gaps in care to identify barriers and solutions. And from that, they developed a model of care with several areas of focus: strengthening community, enhancing pregnancy and family supports, including fathers, and promoting healthy babies. And so this work really resulted in this hub of wellness model to really link the African American ICHIRP communities and work in collaborative between the community, the medical professions, and then the grantees in a way that centered culturally appropriate care. And this is really helped facilitate by some of the work with the African American Babies Coalition that looked at not only just the models of care, but then how do you engage the community about what healthy pregnancy looks like, what parenting and healthy parenting practices and supports, including fathers. How do you look at healthy brain development? In addition, grantees worked on specific care model, developing specific care models. So this is an example from both New Diva, which is Nubian moms, and Diva moms, a combination between our Minnesota Community Care and Open Cities, very qualified health centers, and how they use several different patient care navigators, centering types of group care that kind of really focused on connecting mothers to other mothers going through pregnancy and some of the unique challenges, home and community-based visits, and then support during pregnancy and after pregnancy as well. And then with the advent of the COVID-19 pandemic, integrating telehealth visits into the model as well. And then this is another example from one of the other grantees, North Point, that shows both the kind of internal referrals. And so the North Point's own system of connecting families to social supports, and how if a mother came in contact with any of their own internal support services, they would be referred into the iChirp program. And then also external referrals, and how they would work with other partners outside of iChirp, whether they be Broadway Family Medicine, North Memorial Medical Center, other health institutions that they could then refer their patients into the iChirp model. So they continue to get their medical care actually at those other facilities, but they would get this culturally competent psychosocial support through iChirp. The tribal iChirp was a little bit different focused in that it was initially formed to enhance existing or form new collaboratives that focused really on pregnant mothers suffering from substance use disorder. And so they had three kind of broad objectives: screening and assessment, joint accountability, and shared outcomes between the tribal nations, DHS, and our community partners, and then services for pregnant women, substance-exposed infants, and their families. And so each tribe had their own approach, but they kind of came up with a kind of a overall essential features that really helped lead to their success, including ensuring that culture is at the core of the policy, programming, and daily interactions, using peers with lived experience, keeping and treating families together as a unit, and really preventing the trauma of family separation, eliminating the stigma associated with the use of substance use disorder, and then breaking down silos through improved coordination and collaboration between tribes and their local community partners, and engaging the support of tribal leadership from the very start and keeping them, again, at the center there. And so you can see a quote from the 2019 iChirp legislative report that kind of talks about the real impact of that peer recovery coaches and the community-led support that these tribal iChirps provide. And so both the tribal and African-American iChirp pilot programs have really proven successful in creating community-led collaboratives that improve the health of participating women, and really demonstrating how to have help women and mothers successfully mitigate some of the psychosocial risk factors, improving the care models that are developed around women and that are culturally sensitive and based, improving birth outcomes, decreasing family disruption, and again, continuing authentic community engagement and awareness. So Governor Walz's proposal in his budget to invest in iChirp is the hope to expand services for African-American women in the Twin Cities area in particular. So the current funding that exists is not enough to reach all the women in the Minnesota healthcare programs at this point. And so it's really been funding for a pilot project and hasn't been able to demonstrate population level impact because the funding hasn't been there to scale it up. And so the hope is to continue to scale up the African-American iChirp, and then to build additional regional care collaboratives centered around Duluth, Bemidji, and the Twin Cities for new tribal iChirps that are really, again, following this model of a community collaborative. And those three areas are picked specifically because that's where there is a critical mass of community that is needed to create these collaboratives of our different tribal nations. And so the proposal has a net general fund impact of $1.6 million of additional expenditures in fiscal years 2022 to 2023, and then $706,000 additional for 2024-2025. And so again, just to reiterate that we are seeking increased funding to bring iChirp to scale to really help community advisory bodies create the structure to become self-sustaining. And so the African-American iChirp, for example, is in the process of becoming an independent 501c3, so then it can seek public and private funding to help support and continue its scale up. Continue community relationships that have been built. And I think this is really important. I feel like, as the chair noted even in the last remarks about sometimes getting specific evidence, high quality randomized control trial type evidence can be a barrier to actually working with communities. And so I think we've made a really good investment at this point, and it's really important to continue that to really repair some of the trust that has been broken both by the medical community and the state over time. And so the funding would help continue to educate other medical professionals, as well as law enforcement, judiciary, and other areas that are touched by that impact health outcomes for our mothers and infants. Looking at paraprofessional workforce development. And so the doulas and healthcare workers, or community health workers that are paraprofessionals in this program have specialized training. And so to scale it up, we would need to continue to invest in that development, which isn't generally covered in Medicaid. And then increased connection to other social supports and continue to follow some of the models that we saw there with North Point in particular, connecting it to other both internal and external supports. And the goal is really that ICHIRP can become the standard of care for all African American and American Indian women in Minnesota. So at this point, I'll cede back and take any questions. Thank you for your time.
Thank you very much. And we also wanted to have some sense of how much was spent on these programs. And if you don't have that today, I know the folks at DHS can get that to us, so that, because as we're looking at pools of money, how are they being used effectively? Or are they still effective and meeting their intended purpose? So questions from members? Otherwise, we are going to get a chance to talk some more about medical assistance and DHS's impact. Senator Nelson.
Muted here. Don't know if my camera's on. Dr. Chabello, thank you so much for the presentation. And I would like to ask you kind of the same question. Are you able to tell with socially liked peers what percent are ready for kindergarten, or do you measure, anything? How do you measure? Just there's a number of different metrics. One that I know we often look at is, are kids ready for kindergarten? And doing kind of those paired studies, are you able to share any information with us how kids are doing who have gone through the program that you were describing?
Yeah, thank you, Senator, for that question. Like my colleagues at MDH, were kind of limited in being able to track specifically. And again, this was a pilot project. And so the funding wasn't really even enough to cover, setting up systems of measurement. And so that's one of the things that with the increase in funding, there will be an intent to do with the community's input on measures so you're looking at measures that are not only important to us, but what the community values from the program. I think anecdotally, you'll find if you looked at the 2019 legislative report, and then we continue to find is that mothers and families that participate in the program have more successful pregnancies with carrying to term, not having health complications. We see less family separations due to some of the cycle stressors that come up in pregnancy. And so, children are staying with their parents and in their families at higher, if they're part of the program. But again, we don't have the numbers to kind of power it and look at a population level and say, we for sure can attribute it to this. That's what we hope to do going forward. And certainly we are even, talking with our colleagues at MDH around things like early childhood systems and how can we kind of look to track and see if there's connections between systems like ICHIRP that are set up and how that impacts their success down the road. But and then I just wanted to quick, Chair Benson had asked about the money that's been spent. And so the initial ICHIRP appropriation was $3 million for grant funding over 2 biennia. And then as of 2019, it's been $989,000 annually in the state's base budget. And so that's supported the kind of ongoing grant. And so the increase would be above that to again, continue scaling it up.
Thank you.
Thank you, Madam Chair. Thank you for the important job that you're doing, and look forward to more of those statistics as we move forward, more of those comparisons. Thank you.
And thank you, members. Now we're going to move on to Senate File 735. Senator Wiklund, if you would move your bill, begin your presentation. Members, this will be laid over. I'm looking for things to put in the budget that help meet this goal of impactful and touches 2 generations. And so I wanted to hear Senator Wiklund's language. I'll have some comments at the end, but Senator Wiklund, please proceed.
Thank you, Madam Chair. And yes, I'd like to move Senate File 735 and appreciate being able to have a chance to present it to the committee today. This is a bill that would extend Medicaid coverage for some mothers to 12 months postpartum from the current federal mandate of 60 days, which was mentioned in the previous presentation. The postpartum period is a very important period in a woman's life and is often one that's maybe more neglected than other periods of care. New mothers may be dealing with a host of medical conditions, such as complications from childbirth, pain, depression, anxiety, and they do have to deal with these conditions while they're taking care of a newborn, of course. While Medicaid pays for over 40% of the births and must cover the pregnant women through 60 days postpartum, after that period, states can decide on different levels of coverage, or if to cover the pregnant or the postpartum mother at all after that. So currently Minnesota follows the federal mandate that new mothers must be eligible for Medicaid for up to 60 days postpartum. According to data from DHS in 2020, roughly 10,000 women qualified for Medicaid based solely on their pregnancy, and nearly 40% of these mothers lose their health coverage after at the 60-day coverage end date after giving birth. The United States has a very alarming high maternal mortality rate, and in fact, it's much higher than many other developing countries. And because of this worrisome statistic, we really want to try and find ways to address maternal health and improve maternal health so that we can lower the rate of maternal mortality. To better give you some examples of the high maternal death rate in the US, here's just a few statistics. According to the CDC, around 1/3 of US pregnancy-related deaths occur during pregnancy. 17% of the deaths occur on the day of delivery, and 52% occur after delivery or postpartum, and are broken down into, 19% of all deaths occur between 1 and 6 days postpartum, 21% occur between 1 and 6 weeks postpartum, and 12% take place during the remaining portion of the year. So there's a significant number of deaths that are occurring after the 6-week postpartum period. The U.S. is also, U.S. and Minnesota definitely struggle with high maternal mortality rates amongst racial groups, and even higher rates. So if you look at the numbers of deaths per 100,000 births for Black, non-Hispanic women in 2018 in the US was more than 2 times higher than that for white mothers. So we're really, and then if we look at the impact of the pandemic on Black and Latino communities, they faced higher rates of economic hardship and mental health problems during the pandemic, that we really are concerned that we need to be addressing healthcare coverage to try to mitigate some of these factors. So multiple state maternal mortality review committees, including Minnesota's, have recommended extending Medicaid coverage to 12 months postpartum. Also in December of 2020, the Trump administration released new guidance on improving maternal health outcomes, and one of their recommendations was to approve state requests to extend Medicaid coverage. And last month, the Medicaid and CHIP Payment and Access Commission, which is a nonpartisan legislative branch agency that provides policy and data analysis and makes recommendations to Congress, that they put forward a recommendation, and one of their top recommendations, to extend the postpartum coverage period for individuals who are eligible while pregnant to a full year of coverage, regardless of changes in income. So I have been reading a lot more about this across the country, there are other states that are introducing this type of bill to extend the coverage. And I think it's because we can see that by creating more opportunities for women to receive optimal health care after they've had a baby for up to that, that first year of life for the baby would be better for the mothers and for the children. I do have testifiers who are able to talk more specifically to what they're seeing. And I'd like to have them speak on the bill now. So. Oh, and you're muted, Senator Benson.
Senator Wiklund, we wanted to keep testimony to about 2 minutes per testifier. I'll have a little grace with that, obviously, but let's just get right to the point about why this matters to moms and babies.
Yeah.
Let's start with Dr. Helen Kim. Welcome to the committee. Please begin your testimony.
Thank you, Madam Chair and members of the committee. My name is Dr. Helen Kim. I'm a perinatal psychiatrist at Hennepin Healthcare System based at Hennepin County Medical Center, where I serve pregnant and postpartum women with mental illness and currently serve as the medical director for the Mother Baby Program and the Red Leaf Center for Family Healing. So for 2 decades, I've served at HCMC, serving mainly pregnant and postpartum mothers with mental illness, mainly trauma. And it's so very clear that mothers need insurance coverage that extends beyond the 60 days after delivery. Prenatal and postpartum depression and mental illness affect 1 out of 7 women in general, and as high as 1 in 4 mothers who are at higher risk due to poverty or limited social support. The risk for postpartum depression and other mental health conditions, along with drug and alcohol use, extends throughout the first postpartum year and even beyond that. We know that untreated mental illness and substance use in that first postpartum year and in the first 1,000 days can be life-limiting and even life-threatening to mothers. Suicide is one of the leading causes of maternal death in the first postpartum year in the United States. We also know that those first 1,000 days of a baby's life is a critical window for development, so that when mothers are impaired with depression or other mental illness, that they're less able to care for their children in ways that support development. We know from studies that untreated maternal depression costs on average $32,000 per mother-baby pair due to lost productivity from absenteeism, unemployment, increased healthcare costs, and also poor birth outcomes with children. So we know that helping women and families access effective and affordable treatment for mental illness in particular during that first year will lessen the burden and costs on families in particular and on our community in general, and that we have the opportunity to support generational well-being by ensuring that all mothers have health insurance coverage, again, through that first year postpartum.
Thank you very much. I very much appreciated that you took time to testify here today. We have another doctor, Dr. Maren Flynn from the American College of Obstetrics and Gynecologists. Welcome to the committee. Please introduce yourself and proceed.
Madam Chair, members of the committee, my name is Dr. Maren Flynn, and I'm on the legislative committee for the Minnesota section of the American College of Obstetricians and Gynecologists, and I represent nearly 1,000 providers of women's healthcare in Minnesota. We strongly support Senate File 735. Senator Wiklund has outlined the broad benefits of extended, reliable postpartum medical care, and our association would like to emphasize the urgency. Access to healthcare can literally be the difference between life and death for a postpartum woman. In the United States, it is more dangerous to have a baby now than it was a generation ago, and this maternal mortality rate is rising. Like Senator Wiklund said, we have one of the highest rates of maternal mortality among developed countries, and in addition to that, our rate is actually rising. At least half of these deaths are postpartum. As she said, a significant number are beyond the traditional 60-day window that we cover postpartum care. For women of color, Indigenous women, that risk of death is 3 times that of white women, regardless of their education or socioeconomic status. My patients know these, and they discuss it with me. I also speak from the perspective of someone who has spent a lot of time in my career working abroad with Doctors Without Borders in places where women don't have access to care and there is no medical system. I've attended many maternal deaths, and it is devastating for everyone. These are preventable, and this is the time to act. Pre-pandemic, Medicaid ensured that nearly half of our pregnant moms in Minnesota have high-quality prenatal, delivery, and immediate postpartum care, which contributes to our lower maternal mortality rate. However, more than 40% lost healthcare coverage after 60 days when the qualifying income threshold dropped. Women of childbearing age are getting sicker and at younger ages for reasons that are not clear. The rates of hypertension, diabetes, heart disease, and mental health disorders are steadily increasing, regardless of risk factors. Because their pregnancies are more complicated, their postpartum courses are more complicated, and these are diseases that we can have great impact in the postpartum period. It's important to note that the #1 cause of late postpartum maternal mortality is heart disease. Additionally, as Dr. Kim mentioned, 1 in 7 women suffer from serious postpartum depression. Women with substance use disorder that relapse postpartum are more likely to do so in the 7 to 12-month postpartum period. Access to healthcare works and is vital for the personal well-being of Minnesota's mothers and that of their families and our community. Every woman, regardless of her insurer, employer, or income, should have ready access to the right healthcare for her at the right time. Their lives depend on it. Thank you.
Thank you. And next on our list is Dr. Erica Lara from the Minnesota Council of Health Plans. Dr. Lara, welcome.
Hi, good afternoon, Chair Benson and members of the committee. My name is Dr. Erica Lara, Director of Health Policy and Government Affairs for the Minnesota Council of Health Plans, the trade association that represents the 7 nonprofit health plans in Minnesota. And thank you so much for the opportunity to speak today in support of Senate File 735. The Minnesota Maternal Mortality Review Committee actually recently reported that between 2011 and 2017, African American and Native American women were up to 4 times more likely to die from pregnancy-related issues when compared to white mothers. This data also suggests that almost half of maternal deaths occur in greater Minnesota, an area where the median household income is $23,000 less than the metro area. Here's where Minnesota's medical assistance program can play a significant role in improving Minnesota's maternal health outcomes, as it notably covers a high portion of low-income Black, Native American, and Latin women. In 2018, MA covered about 1/3 of all births in the state, most of these covered by Minnesota's health plans through the PMAP program. Approximately 29% of pregnancy-related deaths occur between 43 and 365 days postpartum, a period in which these mothers are lacking appropriate access to healthcare and whose deaths from complications such as hypertension, stroke, and even postpartum depression may be preventable. Extending postpartum coverage in the MA population beyond 60 days will allow timely healthcare access for mothers suffering from both physical as well as mental health issues. It will improve their child's early development, and most importantly, it will increase health equity by protecting minority, Black, Indigenous, and mothers of color from dying from preventable postpartum complications. The Minnesota Council of Health Plans urges you to support Senate File 735. Thank you.
Thank you. Senator Wiklund, those are all the testifiers that I have. I believe you have an amendment, so let's start moving through amendments and then questions from the committee. And members, we are planning to go long today. We want to give Senator Coleman's bill attention as well, but Senator Wiklund, if you could proceed.
Sure. Yeah, kind of shifting gears a little bit to access to appropriate care postpartum, and specifically midwife and doula care. I wanted to bring forward an amendment. It's the A2 amendment that's been posted. And this is language that is from a bill that one of my colleagues, Senator Torres Ray, is carrying. And it is meant to help address pregnancy and childbirth, midwife and doula care, and to try to have groups work with the Department of Health to improve birth outcomes focus on those groups that are seeing the most significant disparities, including Black, Indigenous, and other communities of color. As were mentioned by the testifiers, Minnesota has a very high disparity between outcomes between white women and Black, Indigenous, and other communities of color. And we need to really focus on finding ways to address that. This amendment would ask the Department of Health to work in partnership with the groups and the communities that it is serving the cultural communities, to help them develop procedures and services designed for making midwife and doula services available to groups with the most maternal and infant mortality and morbidity disparities, promote racial and ethnic and language diversity in the workforce, and ensure that midwife and doula training and education is tailored to the specific needs of groups with the most significant maternal and infant mortality and morbidity disparities. So it would encourage more intentional work. I think the work that Dr. Chamillo talked about, finding ways to work very closely with the communities that are impacted by these disparities to find solutions will help us be more successful in addressing these outcomes and improve outcomes, basically for women and their children. So that's my amendment, Madam Chair.
Thank you. Questions from the committee? Okay, seeing none, I'm going to ask you to unmute, turn on your video, and to Senator Wiklund's A2 amendment. All those in favor say aye.
Aye.
Any opposed? Hearing, I'm sorry, Senator Wiklund, the A2 amendment is adopted. And members, we sent out the A6 amendment. I originally wanted this bill to be a 6-month bill because there's only so much money that's going to fit in my budget, but we thought it was more efficient. Senator Wiklund already had language, but I'm going to see what fits in our budget. This is important work. The reason that I wanted to move 6 months, I thought that was an important milestone for moms and babies when it came to stability in breastfeeding, seeing emerging signs of postpartum depression. And so I was going to try to find the middle ground between the larger Wiklund proposal and where we're at now. Since all of this has happened, there's a federal bill moving, and I am told that there is a portion of that federal bill that would fund 85% of a 365-day postpartum MA proposal, but that it would end after 5 years. And so we're going to have a challenging balancing act, to say the least, when it comes to this expansion proposal. But I'm happy to have questions from members at this point for Senator Wiklund, but I'm not going to take committee time right now to review a fiscal note until we see what that federal bill has and what we can fit into our budget. But the fiscal note is available so people have some sense. The Wiklund proposal in the second biennium would be almost $30 million. We're going to have to see what path we have for these ideas, but we do want to keep pushing help for moms and babies further upstream so we have a bigger impact earlier. So I know we are a finance committee. The fiscal note is available for people to review, but with the changes happening at the federal level, I am concerned that this wouldn't even be a valid fiscal note by the time. I see Mr. Albrecht unmuting. I'm going to let him speak to this provision. Mr. Albrecht.
Madam Chair and members and Senator Wiklund, I just wanted to highlight something in the fiscal note that I think is going to be the case regardless of what happens with the federal law, and that is the implementation date. The fiscal note describes what apparently are extensive systems work that would be needed to do this proposal, to implement this proposal, and says that the soonest it could be implemented is July 1st of 2022.
Okay.
And there are also substantial systems costs. You'll notice the whole first year is systems costs.
Okay. Thank you, Mr. Albrecht. There are substantial systems costs. I see Senator Abler has his hand raised, and then Senator Nelson.
Yeah, thanks, Madam Chair. Just briefly, and this talk about these costs and all that. As a big proponent of doulas and all this, just more sensible birth, that is so nice for women to have. It's, it's too bad we can't have a note that's dynamic, because the complications that are avoided by this, not even just the money, but the impositions and the challenges to the child and the mother and the family and all that. This is just such a superior option. It's too bad that can't be captured. Madam Chair, there was a moment in your committee that I thought we were on to dynamic fiscal scoring, and I just can't imagine that we still don't do that. Because anyway, I just wanted to plug in there. I hope we can do this, Madam Chair. Thanks.
And Senator Abler, I agree. And the reason that I'm enthusiastic about Senator Wiklund's amendment, if we can have doulas and midwives helping moms when they share a culture, when they have shared experiences, I think then we're going to get better uptake and participation in all the other things that we're trying to do for moms and babies. If it's the home visiting programs that are coming up next, if it's staying engaged with their care providers that we would be funding if we expanded medical assistance. So let's have people who have common experiences helping each other through this important transition from not being a mom to being a mom, or adding a new baby to a family. So thanks, Senator Abler. Senator Nelson, next.
Thank you, Madam Chair. And actually, my hand was up for the Wiklund amendment, and so I'll just make a comment. I also support doulas, and particularly matching culture and desire and all of. So I think that's a really good thing. And I think to Senator Abler's point, there definitely can be a decreased cost there. And we always want people working up to the very top of their licensure. And this is a prime example where we could and should do that. I would just note that there was one thing that I thought about when we talked about increasing or decreasing, I should say, infant mortality and complications during birth. I do think at some point we need to make sure that we do have access for those times when there are conditions that require more than what a doula is qualified for, that might require some emergency surgery or intervention in order to help safely deliver that baby. And so I think it's important that we keep all sides of that in our conversation and make sure that we have a full array of options available to women who are pregnant. So whatever fits their particular need and desire, they have access to. And that would include doulas as well. But we also have to make sure that they have that intensive medical option, if needed, readily available.
Thank you. Senator Wiklund, we'll go to you for closing comments.
Thank you, Madam Chair. And again, thank you for hearing the bill today. I just wanted to say that I do plan to speak with DHS some more about the fiscal note, so I make sure I understand how the assumptions they've made in terms of numbers and how the patients would be placed into different programs. And so I hope to work on that some more, and then it'd be great if we can get over the short term some more information about any federal programs that might work for supporting us in this effort. And I also wanted to say, I think that we could discuss, possibly a less than a year, but I think there are a lot of cases where either conditions maybe aren't known readily early on, and as women progress through that first year, I think having access to healthcare really could help mitigate problems with either chronic diseases or mental health conditions or substance use disorder issues that might take longer to address. And having that year of coverage, I think really would benefit moms and I think also their babies. So thank you again, and I look forward to more discussion. Thank you.
Thank you, Senator Wiklund. So members, Senate File 735 as amended will be laid over for possible inclusion in our omnibus budget bill. Next, I would like to welcome Senator Coleman with Senate File 1360. Welcome to the committee. Senator Coleman and Senator Wiklund, I'm going to have you move Senate File 1360 to be before us.
Sure. Happy to move forward Senate File 1360 for consideration.
Thank you. Senator Coleman, if you would begin your presentation.
Yes, well, thank you, Madam Chair and members of the committee for the opportunity to come before you today to discuss this bill. I especially want to thank Senators Benson, Wiklund, and Uyghur for co-authoring this bipartisan bill focusing on cultivating strong mothers and strong families. As you've already heard today, families receiving voluntary home visiting services from trained professionals have access to services that improve pregnancy and birth outcomes for their child, opportunities and support to develop secure attachment, and support to improve their child's physical, social, and mental health development. The benefits to families are compelling, including improved child health and development, improved maternal outcomes, and decreases in child abuse and maltreatment, as well as increased understanding of child development. As most of you are aware, there have been significant investments made into voluntary home visiting services for pregnant women and families with young children. And in order to improve access and outcomes for these mothers and children in need, we need to focus on effective programs with proven results. And this bill really aims to start accomplishing that. So with that, Madam Chair, I want the testifiers to be the ones to tell the story. So I'll now turn it over to them to provide more in-depth information about effective home visiting services and the impact it has on families.
Let's see, we have Laura LaCroix DeLune from the Minnesota Coalition for Targeted Home Visiting, followed by LaSharon McDonald and Joel Flatten. So Ms. LaCroix DeLune, sorry, would you begin your testimony, correct my pronunciation, and proceed?
Great. Thank you, Madam Chair, members of the committee. My name is Laura LaCroix DeLune with the Minnesota Coalition for Targeted Home Visiting. The coalition represents a broad array of nonprofits, local public health agencies, tribal health agencies, and local education agencies that provide home visiting services and programs across the state. As you've heard, many families are served by home visiting programs, and many of these families live in poverty, are experiencing mental health issues, experiencing homelessness or food instability, chemical addiction, or even come from the foster care system. The policy changes that we're aiming to change in this bill do a few things. So specifically to this bill, we're trying to move rider language or appropriations language into statute under a new title. This would also allow up to 25% of the funds to be spent on evidence-informed, promising practice programs, in addition to the evidence-based programs that are already funded through this program. And then we provide definitions for what it is that how we're defining these programs and the outcomes that we aim to achieve through home visiting services. Currently, 10% of eligible families in Minnesota are receiving family home visiting services, and we hope that we can continue to reach those in highest needs with these changes. I will, with the sake of time, I'll turn it over to our testifiers who can speak about their own personal experiences with family home visiting, but I'm available to respond to any questions specific to the bill.
And thank you. Would you introduce your testifiers?
Yes, please. LaSharian McDonald will be with us from St. Paul Ramsey County Public Health.
Welcome to the committee. Please state your name for the record and proceed.
Yes, my name is LaSharian McDonald from St. Paul Ramsey County Public Health. Chair and members of the committee, I appreciate the opportunity to come before you to request funding to support for voluntary home visiting services for all eligible families in Minnesota. I myself received home visiting services because I got pregnant in the 8th grade while I was 14 years old. And, you know, being a teen parent, you get your fair share of judgmental looks and comments, you know, those looks and comments. Oh, can you hear me?
Yes, we can hear you. Please proceed.
Yes, and those looks and comments filled me with guilt, shame, and embarrassment. So I was living in poverty when I got pregnant, so I had to get on welfare and sign up for WIC so that I could provide for my baby when he was born. WIC referred me to Ramsey County Public Health so that I can receive home visiting services. So during that time, I began meeting with my first public health nurse when I was pregnant throughout my son's first year. I moved out of Ramsey County, then came back when my son was almost 3, and then I started receiving home visiting services from my second public health nurse. So during the visits with my first public health nurse, she would measure my stomach, weigh me, educate me on how my unborn child was developing in my womb. My first public health nurse was also supportive emotionally because she made sure that we always had time to talk about what I was struggling with that week. After my son was born, a public health nurse would weigh my baby and do screenings to make sure that he was on track developmentally. And my public health nurse would also ask how I was coping with being a new mom. With my second public health nurse, we would talk about parenting topics such as health and nutrition, discipline, and she connected me to resources as far as like food shelves, employment services, and mental health services. And she helped me to understand my child's developmental behaviors through developmental screenings. And again, she was always super supportive and made sure that I was okay and see what else she can do to support me and my child. So meeting with my public health nurses was always the highlight of my day. Home visiting was important to me because my public health nurses never judged me. When they looked at me, they didn't see just a teen mom. They saw a mom who was trying to raise her son while completing grade school on welfare. I felt listened to and heard during my visits. My public health nurses educated me on the skills I needed to become the parent I wanted to be and to parent the best way I could. I felt my public health nurses understood me because of the empathy they displayed to me. And they helped me to finish school as a teen mom while making sure that my basic needs were met and being emotionally supportive. So after I graduated from high school, both my public health nurses wrote me letters of recommendation for my St. Catherine University admissions application. So I graduated from St. Kate's in 2017. Now I'm employed at the exact same organization and work in the exact same unit as my public health nurses. So I'm officially out of poverty. My son is thriving. I'm a mom of 2 boys now, and I'm married. And I truly feel like a better mom, professional, and woman because of home visiting. So now that I'm a home visitor, I love what I'm doing. You know, the whole reason why I went to St. Kate's was to obtain a degree that would allow me to become a home visitor, I feel like, you know, it's my turn to reach back and help get young moms out of poverty. I know a lot of what my clients are going through because I've walked in their shoes. I just hope to be a reminder to moms that, you know, you can get out of poverty, raise your kids in a healthy way, and live the life that you want. You know, I enjoy bonding with the families, helping them get connected to resources that they need. I enjoy working with moms on building healthy attachment with their children, talking about child developmental topics and the well-being of their family. Overall, I truly feel like I'm making an impact on the families that I serve, just like my public health nurses made an impact on my life. Thank you all.
Thank you. And I believe next is Joel Flatten.
Sorry, I had to find the speaker. Madam Chair and members of the committee, for the record, my name is Joel Flatten. I'm the Executive Director for Supporting Hands Nurse Family Partnership, which is now a 21 county collaborative. As Ms. Reckinger said, that we expanded into Sibley County. So we took one of those 6 counties that didn't have it. So we're offered out in West Central Minnesota, and we do the NFP program for home visiting. It's the first time pregnant mothers or children and families. Out here, providing quality home visiting programs in rural communities is essential, as there's limited services that provide intensive supports to this targeted population. We really don't have a lot of competition or a lot of different programs out here. Our main one would probably be early Head Start. So otherwise, there's not a lot of supports in our area. The mothers and families work with deal with multiple issues such as mental health, substance abuse, isolation, interpartner violence, and past trauma. We have definitely seen during this past year of COVID increase in the mental health parts and interpartner violence, some of those areas. We work hard to help stabilize families through home visiting prevention services and often see the best results when parents really engage with their home visitor, as LaSharon described. LaSharon's story is a story of many of our mothers who have overcome difficult backgrounds and have gone on to be great mothers and contributors to society. We know COVID has had a disproportionate impact on families. More families are facing housing and food instability and are feeling more isolated. Additional resources and attention to these families will be critical as we build back from the pandemic. Ultimately, we want to increase access to these voluntary services to families that are interested and increase family home visiting resources. Our goals are similar to other programs, is to empower women, mothers, and families to support their child's cognitive development, improve health outcomes, and work towards self-sufficiency through education and employment. We know our home visiting program makes a positive impact on the lives of families served, as told by our nurses through numerous stories of supporting mothers, children, and their families. In many instances, sadly, this is the first positive adult relationship that some of these mothers and families have had. We hope that the legislature will continue to support as we're growing this home visiting so that these programs can continue to impact healthy futures for families. Thank you so much.
Thank you. Senator Coleman.
Well, thank you, Madam Chair, and for members of this committee for hearing out this very important bill that I think furthers our goal of having strong mothers and strong families through effective programs. And I will continue to advocate for this bill moving forward and hope to be back before this committee very soon.
Thank you, Senator Coleman and members. The A1 amendment, I'm not going to offer it at this point. Again, this bill is going to be laid over. I want to be clear, any funds that go to this would come from existing funds that had been issued in a rider years and years ago. And so we would just be making this clear. My goal before Senator Coleman had this bill was to take all of the home visiting that was done via grants and put it into its own place so that we could make sure we were meeting high standards and that we're measuring outcomes. And so this bill is the 90% step to get us to high standards and effective home visiting programs. This will be in our omnibus budget bill. I want to make sure, again, we have the right balance between high standards and allowing flexibility for emerging practices in communities that have not traditionally had home visiting. So communities of color or Native communities that might need a different model. So we can have Minnesota be one of the places where we're developing the most effective models with cultural competency. So that's my goal for this language. And with that, I'm going to ask Senator Wiklund. Well, actually, I'll just lay over Senate File 1360 for possible inclusion in our omnibus budget bill. And members, we're going to try to push taking care of moms and babies upstream to be as effective as we possibly can, starting early and focusing on brain development and strong bonding between moms and babies. I think it has been proven to bear fruit, but we're going to need to document it and deliver on the promise. And so with that, members, I'm going to let Senator Coleman or Senator Wiklund make any closing comments.
Thank you, Madam Chair. I think I touched on it in my last remarks if Senator Wiklund had anything she wanted to add.
Thank you, Madam Chair. I would just say I've been supportive of the work that they've been doing, that the Targeted Home Visiting Coalition has been doing over the past few years. And I too appreciate that there are the evidence-based programs. There's other programs that are also important to give a chance to work. They serve some other communities and serve some other needs. And so I'm glad that we have some flexibility. And then I think also you're mentioning that, tracking outcomes is really important. And hopefully we can be gathering data that can eventually connect up with, I think as Senator Nelson was alluding to, our early childhood longitudinal data system. There are people in MDE and other places working on that system. And if we can connect the outcomes, that would be excellent to be able to see, where programs are most effective. So that is a work in progress, and look forward to more happening there.
Thank you. And Senator Wiklund, you had mentioned Senate File 877 that was Senator Torres-Ray, and there is a morbidity data collection in there that I'm concerned about. So I'm trying to find a proxy for how we measure good outcomes for moms and babies. And maybe it's NICU days per 100 babies, or we find some other proxy for showing that we are improving healthy deliveries. So I'm willing to work with anybody to find a solution, but I also want to protect the privacy rights of moms. So with that, members, thank you for your attention. We will have more work to do on Wednesday. And with that, we are adjourned.